Hello.
Hello, sir.
Good afternoon.
Good afternoon, sir.
Okay. So I think we need to address this problem. You see, once you are in a group like this, I mean the WhatsApp platform, you have to be active on the platform because you know that every information, all that we need to know, will be sent through that platform. So when we send any info there and then, especially you wait, you don't go to the platform, you don't check the information there. Then you wait and almost 3 minutes to the meeting. Especially if I'm the one taking the meeting, then you are now contacting me because I need to join the meeting too and then start. You wait till just 5 minutes, 2 minutes, and then you now call me or you contact me telling me that you haven't received the email. Meanwhile, you know that you need to get the email before you join. Please, you have to be active on the platform. You have to be active. If we send anything there and direct you to do it, please do it. Else, it will not help, please. Vice Captain, I hope it's clear. Please. Hello. Hello.
Hello, sir.
Okay. So can you see my screen?
Yes, please, sir.
Okay. All right. So as we said yesterday, your meetings will normally be on Saturday. Still preparing to meet you. Then I have to take the opportunity and then add this Sunday meeting. So the two groups are doing the anemias. We also do the hypertension together. But the other topics, as I said yesterday, the couple and then tackle them separately. Will normally be on, and therefore today we are switching from anemias. Next week Saturday we will still continue with the anemias. So on Sunday, preparing to meet you with different topics. I have to take the opportunity and then I would want us to discuss. But the other topics, as I said yesterday, some of the GIT and then tackle separately. Will normally be ulcer disease. And therefore today, I understand this topic. We are switching from anemias. One of the next week common ones, but still continue with the anemias. So on Sunday, preparing to meet you with different. You've had the chance to discuss it before in your various schools. You've been taught CAS, PUD, but the other topics, as I said, some of the GIT and then your meetings will normally be on. And therefore, today, if you have any contribution, you can add. If I ask any question, I expect. For this one, I know that you are on top of it, so that we can move very fast and then finish, however, not compromising how you understand the whole topic. All right, so PUD, Class Captain, are we free to start? I don't know if some people are still waiting. This topic, we are switching from anemia, accepted. One of the next week common ones, and move very fast and then finish, however, not compromising. Hello? Do we still have people waiting? Hello? Please, can you hear me? Am I still online? Can you hear me?
Yes, please, sir. We can hear you.
Yeah,
Sir, please, I think
Yes,
course
sir.
records are not yet in.
All right, so let's start. So before we look at the disease, let's look at where where in the body this problem normally occurs. So it's either affecting the duodenum or the stomach. And of course, when we say peptic ulcer disease, look at it as an injury to the mucosa. So when you have a break in the mucosa that at least extends deeply to not less than 3 millimeters inside the mucosa, then we say that there is peptic ulcer, of course, stomach or the duodenum, the so-called gastric and duodenal ulcers, respectively. If it's stomach, we call it gastric. If it happens in the duodenum, we call it duodenal ulcers. If you are not lucky, it can even extend deeper all the way into the muscularis. So you can see the top here is supposed to be the endothelial weight of it. You attack a lumen of the GIT, specifically the duodenum and the stomach. So as you move deeper into the lining, you meet the mucosa. So if the break in the continuity, it extends deeper to at least 3 millimeters. So you have an injury here, and then it extends very deep down. Then you say that this is an ulcer, provided it happens within the stomach or the duodenum. If you are not lucky, it can be very deep, such that all the way the injury can be very deep, so it moves all the way from the perforations altogether. And therefore, it is very important that when you suspect and maybe confirm the presence of peptic ulcer disease, whether in the stomach or the duodenum, you pay serious attention and cure it. It's curable. It can even lead to somebody dying, and therefore you don't take it for granted. Once it is identified, you must be able to control it accordingly. Now, within the duodenum and the stomach especially, there are various areas that are very important to the development of peptic ulcer disease. For example, looking at the stomach, there are various sections where you have some of the etiologies. For example, H. pylori residing.
Hello,
Yeah.
sir.
Hello.
Please, I can see your screen.
Let me ask the others. I don't know if it's from your side. Please, can you see my screen?
Yes, sir.
Yes,
Yeah,
sir.
it's showing.
Okay. So if you look at the stomach, there are areas where you have some of the etiologies residing. For example, the antrum of the stomach. This area is where normally one of the key etiologies called H. pylori resides. If you look at the fundus, you will have cells like the parietal cells also situated there. And these parietal cells are the cells that will secrete the HCl. So it's very important that you have a fair idea of some of these structures within the stomach and the duodenum. So this upper curvature here of the stomach is called the fundus. What follows is the main body, otherwise called the corpus. The corpus. Then, if you go to the lesser curvature here, with the gastric ulcer will occur, you realize that most often the injury will be found around the antrum of the stomach. The antrum is where H. pylori resides in the stomach. Then very close to the junction between the stomach and the duodenum is called the pylorus. The pylorus. And after the pylorus, you have a sphincter that separates the stomach from the duodenum. And this sphincter operates such that it allows the movement of substances in and out in between the duodenum and the stomach. And therefore, it is called the pyloric sphincter. At the upper part here, between the esophagus and the stomach, there is another sphincter there that also regulates the movement of substances in and out from the duodenum to the stomach and back from the esophagus to the stomach and then up again into the esophagus. That one is called the lower esophageal sphincter. This sphincter, if it fails to function properly, and it allows substances within the stomach to move upwards, that is when normally one of the basic causes of another GIT discomfort, known as the gastroesophageal reflux disease. Now, from the pyloric sphincter, then you move into the duodenum. And the early aspect of the duodenum is where mostly duodenal ulcers will occur. That is where duodenal ulcers will occur. And that is the same area where if H. pylori will be found within the duodenum, you realize that it resides. Of course, it is close to the antrum as well, not far. So it's not surprising for you to see H. pylori also here. So remember the two common areas where if ulcer will occur. In the duodenum and the stomach, you may find it. The early aspect of the duodenum and the lesser curvature of the stomach. Remember the fundus as one of the areas where parietal cells, very, very key in the development of ulcer, normally will be situated. Then the antrum in the stomach is where one of the most important etiologies of peptic ulcer disease stays. When you are infected with it, it will stay there. Having said that, it is also very important to appreciate the various cells within the stomach and the duodenum, what they secrete, and the contributions of their secretions to peptic ulcer disease, so that we'll be able to appreciate this condition very well. So, number one, arguably the most important cell when you are considering peptic ulcer disease, parietal cells. As I said, they are mostly located in the fundus, the upper curvature. After the fundus, the corpus of the stomach follows. So you can also find some parietal cells in the corpus, also known as the body. These parietal cells are the cells that will secrete hydrochloric acid. Hydrochloric acid. My lady, the one who couldn't see my screen, are you there? I need to know your name. Please, what's your name?
Yes, please.
Your name, please.
Sir, please, I'm Lana Amwa.
Amwa.
Yes, please.
Is it Linda or
Lana?
Lana? Okay. All right.
Yes.
Lana. HCl. Can you cite some of the functions of HCl in relation to the GIT? So why do we have HCl being secreted in the GIT in general, considering all possibilities? What are the roles or functions of HCl in the GIT? The parietal cells are secreting HCl. What for?
Sir, please, it helps in the activation of digestive enzyme. Yes.
For
And it
example,
provides acidic.
for example,
For example, pepsinogen to pepsin.
pepsinogen to pepsin. Excellent.
Yes.
Excellent. Excellent. What else? HCl. Apart from being the bad guy, contributing to ulceration, what you have said is on point. Can you cite another rule? HCl. Why HCl? One of them is to activate enzymes like pepsinogen for it to become pepsin. That will help in protein digestion. Perfect. Lana, can you cite another rule? HCl. Open up. Anything at all is possible.
So please, and I also think it maintains pH, like acidic pH in the stomach, which also helps with the protein digestion. And that's what I mean.
Okay, so it comes down to the same digestion. So do you appreciate that acid can also kill? You appreciate acid is harmful and it can kill infectious agents. Yes, so as part of immune function, the food that we eat, the water that we drink, they are not sterile. Once they are open to the atmosphere, that alone. You remember when you were doing sources of contamination, microbiology. I think that's the first topic that we do, sources of contamination. Even within the so-called microbial lab, that's supposed to be sterile, you still had grooves on the agar that was exposed to the atmosphere, the room, that lab. And therefore, when you take one shot of banku or fufu, once it is exposed to the environment, it's never sterile. And therefore, HCl is there to help you reduce the load of potential infectious agents that you swallow. So by way of immunity, HCl will also help us. Very well. Then we have chief cells. Chief cells, or Henne cells, These are also located within the fundus and the corpus again. So the same areas where we have our parietal cells, chief cells are also there. And chief cells are responsible for the secretion of pepsinogen, the precursor of pepsin. If acted upon by HCl, it becomes active. So the active form of pepsinogen is pepsin, crucial for digestion of proteins. Then we have G cells. These are found within areas like the pancreas, the pyloric antrum, the antrum of the stomach, and the duodenum. These G cells secrete gastrin. Anybody, the rules of gastrin in GIT. Gastrin. Any example of the role of gastrin in the GIT? All right, let me take this one. So gastrin is one of the hormones or the agents that are responsible for the secretion of HCl. It has its receptor called the cholecystokinin 2 receptor, CCK2 receptor, cholecystokinin 2 receptor on the basolateral membrane of the parietal cells, as well as on enterochromaffin-like cells. And gastrin is secreted from any of these areas, either the pyloric antrum, duodenum, or pancreas. It can act directly on the CCK2 receptors on the parietal cells and contribute to the secretion of HCl. Indirectly, it can act on its receptors, the same CCK2 receptors, on enterochromaffin-like cells. These enterochromaffin-like cells are also found in close association with parietal cells, often found within the oxyntic regions of the GIT. Oxyntic regions are the regions where acid is produced and secreted. Oxyntic regions. Oxyntic, like you are spelling oxygen. Oxyntic regions. These enterochromaffin-like cells are found there. They have a lot of histamine stored in granules. And when gastrin acts on them, these enterochromaffin-like cells will release histamine. And after that, histamine will act on its receptor on the parietal cell, contributing to acid secretion. So gastrin can have a direct effect on acid secretion by acting on its receptor on parietal cells, or indirectly act on its receptor on the enterochromaffin-like cells, causing histamine release from the enterochromaffin-like cells. Then histamine will act on histaminergic H2 subtype receptors and cause acid secretion from the parietal cells. So gastrin can also contribute to ulcer, both direct and indirect pathways of acid secretion. And therefore, individuals with gastrinomas, they are seen to release excessive amount of HCl, a phenomenon known as the Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. If the G cells, they misbehave and do overboard, they secrete excessive amount of gastrin in gastrinomas, right, and indirect acid secretion syndrome. We also have delta cells, also found within the stomach, the pancreatic islet of Langerhans, and the intestines. They secrete somatostatin. Consider the name statin, static. It means stop. Static, statin, somatostatin. This hormone in general regulates the activities of several other hormones. It is non-specific, and therefore, if you are a hormone and you are misbehaving, you are doing too much, you are doing more than you are supposed to do. When somatostatin is around, it can command you to misbehave. Stop misbehaving. Comport yourself. It will stop your further secretion. So it's not only acid secretion, it can control acid secretion, it can control gastrin, even insulin secretion, several other hormones. If you have somatostatin around and they are being secreted excessively, somatostatin can check on them and reduce their secretion. So if you have enough somatostatin, of course, any of these hormones or secretions can be put to check. Then we have the superficial epithelial cells. These cells, they run from the duodenum, the stomach, the esophagus, every aspect of the intestine from A to Z. You will find superficial epithelial cells there. What do? They are the cells that will secrete mucus and bicarbonate. Very, very crucial in the defensive mechanisms of the GIT. Very crucial. So superficial epithelial cells, as the name suggests, superficial. So they are found lining on top of the GIT. And their job is to prepare and, under the command of certain hormones, secrete mucus and bicarbonate to help protect the GIT lining from harmful substances like digestive enzymes, pepsin, HCl, so that the injury will not occur. Which means that if your superficial epithelial layer begins to stop producing these protective factors, that alone can put you at risk of peptic ulcer disease. Any questions so far? Any questions? Any contributions? Any issues? If not, class captain, do I have your permission to continue? As I said, if you have any question, you don't need to put it in the box. Kindly unmute and ask your question. All right. Now, these hormones, these peptides, these secretions are always being secreted within the various aspects of the GIT. Here, more importantly, the stomach and the duodenum. And they are always under the command of certain controls, be it central or peripheral input. If I say central, I'm talking about the central nervous system. Peripheral, I'm talking about the peripheral nervous system. So it is the nervous system that will control the secretions that have been mentioned. Of course, it means that there are mechanisms in place to command the various cells within the various locations. And then that command is being controlled, or it will come from either the central nervous system or the peripheral nervous system. Common regulators that involves the neural regions normally will be under the control of the parasympathetic system. And the moment we mention the parasympathetic system, you cannot think far, but focus on acetylcholine as the most important agonist. The most important agonist when you mention the muscarinic system. And of course, the moment you mention the muscarinic system and you are talking about the peripheral nervous system, then you are focusing on the muscarinic subtype receptors. Here in the GIT, the subtype that we have here is the muscarinic M3 subtype. So under the neural control, that is the peripheral nervous system, you have the one that is being controlled by the parasympathetic system. And in the GIT, the receptor subtype of interest is M3. If you are talking about paracrine issues, you know we have autocrine, paracrine, and endocrine functions. Autocrine is any cell or tissue that releases any hormone, and the hormone acts on the same cell or tissue that releases the hormone. Paracrine, that cell releases, and the hormone affects nearby regions, nearby cells. Endocrine, the gland releases, and the hormone gets into the bloodstream. It travels to a distant area and acts on a certain effector organ. I repeat, autocrine, a gland that secretes a hormone, and the hormone affects that same gland that secreted the hormone. Paracrine, a gland secretes a hormone, and the hormone affects nearby effector organs. Effector organs that are close to the gland are affected. And endocrine is when a gland secretes a hormone. The hormone enters the bloodstream, it travels to a distant area far away from the gland, and it has its effect on a certain effector organ. So histaminergic inputs, you have histamine within the enterochromaffin-like cells, just around where you have parietal cells in the oxyntic region of the GIT. As I said, oxyntic means acid secretion. So at the basolateral membrane of the parietal cells, very close to that area, you will see enterochromaffin-like cells. And it is these cells that houses a lot of histamine stored in their vesicles. And by way of paracrine effects, under the input of gastrin, as an example, these enterochromaffin-like cells will release histamine. And with paracrine effect, the histamine will act on its H2 site type receptor on the nearby parietal cell. So you have not only neuronal input, but also paracrine. An example of the paracrine input is the release of histamine by the enterochromaffin-like cells. Then we have endocrine effect. A typical example is gastrin being secreted by the G cells of the pancreas. The pancreas releases gastrin from its G cells. It enters the bloodstream. When it gets to the enterochromaffin-like cells and or the parietal cells, it locates its receptor, CCK2, cholecystokinin subtype 2 receptor, and this results in direct and indirect acid secretion. Now, this is a representation of some of the things I've been saying. Consider this box as the parietal cell. This blue box is the parietal cell. This section is where the lumen is. So here is the lumen of the GIT, and therefore the membrane facing the lumen, the cavity of the GIT, is the apical membrane. Apical membrane. Opposite to the apical membrane, that is on the other side, will therefore be the basolateral membrane. So the membrane that faces or have a contact with the lumen of the GIT is the apical. Opposite will be the basolateral. So if I say that you have histamine subtype 2 receptors on the basolateral membrane of the parietal cell, this is what I mean. If I say that the proton pump is located within the apical membrane, this is the proton pump. Of course, it should be here because the HCl is secreted into the lumen. The lumen, of course. So you can't have the proton pump at the basolateral membrane. If it happens and the acid is secreted, how will it get to the lumen? So this is an example of a parietal cell. The apical membrane having the proton pump, basolateral membrane having several receptors, including the M3 that controls the neuronal aspect. You can see CCK2, that is the receptor for gastrin. You can see the histamine H2 subtype receptor. Of course, the agonist will be histamine. You can also see the EP3, that is the prostaglandin receptors, subtype 3. That one too has a role. With this, we are going to discuss. Now, I'm saying that it has here. Example, is directly seen or indirectly. CO3, and of course, these defense mechanisms of the GIT. The mucus will form a raft and cover the surface of the endothelial cells such that it prevents the endothelium it can be digested. And digestion means that you are creating injury. The ACL factors. Bicarbonate obviously will go into an acid-base reaction and try move the substance from. Then you will need energy before you can successfully push any molecule from a region of lower concentration to a region of higher concentration. And therefore, this pump, this enzyme is an energy-dependent enzyme. It utilizes ATP to pump hydrogen from the parietal cells against the concentration gradient into the lumen of the stomach or whatever region in the GIT. Now, let's look at the pathways. Now, the neuronal pathway controlled by acetylcholine. ACH stands for acetylcholine. So through muscarinic inputs, acetylcholine is released. Neuroeffector junction. The effector organ here is parietal cell. The receptor for acetylcholine on it is the muscarinic subtype 3. So the moment you have parasympathetic activation and acetylcholine is released at the neuroeffector junction, the effector organ here is parietal cell. The acetylcholine acts on the M3 subtype receptor. Of course, muscarinic receptors, histaminergic receptors, and even cholecystokinin 2 receptors, alpha receptors, mostly are G protein coupled receptors. G protein coupled receptors. So when acetylcholine acts on this, obviously, for muscarinic class captain, you are the pharmacologist. Yeah, I did pharmacology some way back. Now, for muscarinic pathway, which G proteins or which enzymes are connected to the muscarinic receptors? Considering this pathway utilizing calcium, we see that is a calcium-dependent pathway. So can you predict the enzymes or how the G protein coupled receptor M3 will pass through its signal transduction processes? You did pharmacology not long ago. Okay, so this one is linked to the activation of phospholipase C. Phospholipase C. So it activates phospholipase C, and once phospholipase C is activated, you know that the second messengers can only be diacylglycerol and IP3, inositol triphosphate. IP3 inositol triphosphate. IP3 releases calcium from endoplasmic reticulum, and through this, calcium can cause the release of HCl through the proton pump. I repeat, under neuronal input, specifically parasympathetic activation, acetylcholine is released at the neuroeffector junction. Parietal cell is the effector cell here. It has the muscarinic subtype 3 receptor, which is a G protein coupled receptor that activates phospholipase C. When phospholipase C is activated this way, second messengers are produced as part of the signal transduction. IP3, inositol triphosphate, and diacylglycerol. Diacylglycerol will activate protein kinase C, but IP3 will act on endoplasmic reticulums, releasing calcium. And when calcium is released, you know that vesicles are only going to fuse with certain membranes to release neurotransmitters and others. Here, calcium will cause the release of hydrogen through the parietal cell into the lumen against the concentration gradient of HCl, and therefore the proton pump will have to utilize energy. It's an energy-dependent pathway. This is one of the 3 pathways through which acid is secreted by the parietal cell. The second one is the direct gastrin pathway. The direct gastrin pathway.
Hello, sir.
Yeah, hello.
Sir, please can you repeat what you just said?
Okay, so I'm just trying to refresh you your basic pharmacology, signal transduction, peripheral nervous system, the autonomic nervous system. Remember, you did parasympathetic and sympathetic pathways, the so-called signal transduction, the process where extracellular inputs are acted on cells, and then through intracellular signaling pathways, it results in changes in physiology of the cell. You get results, signal transduction. So I'm saying that one of the pathways through which acid is secreted by the parietal cell via the neuronal pathway is via the parasympathetic pathway. Acetylcholine is secreted, and because we have muscarinic subtype 3 receptors on the basolateral membrane of the parietal cell, acetylcholine is an agonist, and therefore it activates these muscarinic subtype 3 receptor. This receptor is a G protein coupled receptor that, when stimulated, it activates phospholipase C. And the moment phospholipase C is activated, you are going to get 2 possible second messengers as part of the signal transduction. These messengers can only be inositol triphosphate, that is IP3, and diacylglycerol. If you are looking at what diacylglycerol will do, it will lead to the activation of protein kinase C, and that can cause fusion of vesicles and whatever, causing secretions, either hormones or peptides or whatever. But with IP3, it causes the release of calcium from endoplasmic reticulum within the cell. Endoplasmic reticulum are the calcium storing organelles within cells. And in the presence of inositol triphosphate, the calcium stored in the endoplasmic reticulum is released. So the M3 receptor activation by the acetylcholine via the IP3 as a second messenger will cause calcium release. And this calcium is the agent that enhances the acid secretion through the proton pump. So that is one of the three pathways of acid secretion. The neuronal pathway via the parasympathetic inputs. Please, are you okay?
Yes, please, sir.
All right. Then let's consider the second one. That is the endocrine. You remember the three that we cited here? We cited neuronal, paracrine, and endocrine. So we are done with the neuronal inputs as a regulator, one of the three regulators of acid secretion. We are now looking at the endocrine. So endocrine is when a gland secretes a hormone into the blood, the hormone travels to a distant organ, then it exerts a regulated pathway. So you can see that gastrin, for example, coming in from the pancreas, the G cells of the pancreas, because we have gastrin receptors also at the basolateral membrane of the parietal cell, that is the cholecystokinin 2, CCK2 receptor. Directly, gastrin can attack this receptor. It is also a G protein coupled receptor that can activate phospholipase C, and through the same pathway as discussed under the neuronal pathway, IP3 as a second messenger will release calcium from endoplasmic reticulum, and this will also result in acid secretion through the proton pump. So it is a common thing with neuronal and gastrin input. They all utilize.
Yeah, please. You were breaking, so I barely heard you.
Okay, so under the endocrine pathway, we have gastrin being secreted by the G cells of the pancreas, as an example. It gets into the blood, travels to the oxyntic area where we have the parietal cell. And at the basolateral membrane of the parietal cell, there we have the CCK2 receptor, a G protein coupled receptor that, if activated, can stimulate phospholipase C. And once phospholipase C is activated, it's the same as what we have discussed for the muscarinic pathway. You get two second messengers, inositol triphosphate and diacylglycerol. Diacylglycerol activates protein kinase C, and then some responses occur. With IP3, it releases calcium from the endoplasmic reticulum. And that's just like what we discussed for the muscarinic pathway, will cause the acid secretion. So note that both the acetylcholine, that is the muscarinic pathway, and the gastrin pathway, the direct one, they are both calcium-dependent pathways. And therefore, anything that can increase the amount of calcium in the parietal cell has the potential to cause acid secretion via one of these pathways, either the gastrin pathway, that is the direct one, or the muscarinic pathway. So, if you remember, you know that if you use a calcium-containing antacid, they say that one of the side effects is what? Rebound acid secretion. Class captain, do you remember this? My class captains, are you there? I'm supposed to have Bright. Bright, are you around?
Yes, please.
Since this class is for yes. So do you remember that they say calcium containing antacids will cause acid rebound effect? You remember? So if you have an antacid that contains calcium, the side effect is what? Rebound acid secretion. This mechanism accounts for that. Once these two processes, their end result is to cause acid secretion, and they need calcium. You bring in more calcium, of course, then you are enhancing these two pathways. This is how or why they say that calcium containing antacids can cause rebound acid secretion. Good. Gastrin doesn't only cause or affect the direct acid secretion via the CCK2 receptor. It can also cause an indirect acid secretion via the histaminergic pathway. So again, gastrin has been released within the auxentic regions of the GIT, that's the acid-producing regions. Close to the parietal cells are the ECL, that is the enterochromaffin-like cells. These cells do have CCK2 receptor on its surface. They store histamine, as you can see, in vesicles. The moment gastrin acts on the CCK2 receptor and activates it, a signal transduction will begin. The end result is to cause the release of histamine from the enterochromaffin-like cells. When histamine is released within the auxentic regions, you will have the H2 receptor subtype also on the basolateral aspect of the parietal cell. Obviously, histamine is an agonist. It will act on this receptor. This time, it's not passing through the phospholipase C pathway. This histaminergic subtype 2 is also a G protein coupled receptor. And of course, for G proteins, you can have examples like the I, the Q, and the S. The I subtype of Gs, the Q subtypes, and the S. The S stands for the stimulatory ones. The I stands for the inhibitory ones. And then the Q stands for those that can activate phospholipase C. So with this, the H2 receptor is coupled to the S type, the stimulatory G protein. So it's coupled to the S type G protein, histamine H2. And once it is stimulatory, it can only cause the production of cyclic ANP, meaning it will activate adenylyl cyclase. I repeat. This is histamine H2 is coupled to the SG protein. So it is stimulatory in nature, not inhibitory. Inhibitory will inhibit adenylyl cyclase and block cyclic AMP production. But being an S-type link, it means that it is going to stimulate adenylyl cyclase, and then ATP will be converted to cyclic AMP. And when cyclic AMP is in play, you are only going to activate protein kinase A. And protein kinase A can cause the release of numerous secretions, including HCl, through the parietal proton pump into the lumen. I repeat, histamine subtype H2 receptor is coupled to the S-type G protein. So it's a G protein coupled receptor. And that G protein that it is coupled to is the stimulatory type. The stimulatory types will stimulate adenylyl cyclase. And adenylyl cyclase will convert ATP to cyclic AMP. Cyclic AMP activates protein kinase A. And that can result in numerous secretions. Typical example within the parietal cell is the release of acid. via the proton pump. So as the first two pathways, the neuronal and the endocrine, utilizes calcium pathway, the histaminergic pathway utilizes cyclic AMP. Note the difference. So these are the three different pathways. But the common thing among all the three is that it doesn't matter which pathway that you are utilizing. At the end of the day, all the three will have to cause the acid secretion via the proton pump. And now, if your patient is having problems with acid secretion and you want to prevent that by reducing the acid secretion, strategies that you can employ is to block some of these receptors or block their pathways or block the final point, which is the proton pump. If you are smart enough, why do you waste your time on individual pathways whilst they all converge on or at a common point? Why not block this? So if you block this, then you are very smart. Some individuals may also decide to block the individuals. But mind you, if you block the histaminergic pathway, acid cause acid secretion, and therefore you may not be able to reduce the secretion to any clinically significant extent. But agents or strategies that can block this pathway can cause extensive acid secretion reduction. This in part explains why proton pump inhibitors as agents that decreases acid secretion are superior to, for example, the histamine H2 receptor subtype antagonist, example cimetidine. Because you block these receptors, we still have two other pathways, the neuronal and the endocrine. They can still cause acid secretion. If you block the muscarinic pathway, the remaining two will cause acid secretion. But if you block the proton pump, you have indirectly blocked all the three pathways. Hello? Please, can you hear me?
Yes, sir.
All right. Somebody is trying to call. I don't know why. So now, you can have agents that will come. You can also have a strategy to block some of these pathways. Hello? Can you hear me?
Yes, please, sir.
Hello? Okay. For example, under the influence of prostaglandins, of course, you know how prostaglandins are produced. Prostaglandins too, they have their receptors at the basolateral membrane of the parietal cell, the EP3 subtype receptor. And prostaglandins produce from arachidonic acid metabolism, the COX pathway. If it attacks the EP3 receptor, it is also a G protein coupled receptor. By this time, the EP3 is G protein. Remember, the H2 is coupled to the stimulatory type, the S-type G protein. The EP3 on the parietal cell is coupled to the inhibitory type G protein. So when prostaglandins, for example, the E2 subtype, prostaglandin E2, attack the EP3 receptor, it inhibits adenylyl cyclase, which becomes the opposite of what happens when you stimulate the H2. So the moment you inhibit adenylyl cyclase, you are not producing cyclic AMP, and therefore you can't release acid via the H2 receptor input. So prostaglandins, when they are around, they can antagonize the histaminergic pathway by inhibit adenylyl cyclase. and preventing the acid secretion. So prostaglandins can be utilized to minimize acid secretion. Why? Because when they act on the EP3 receptor, it is coupled to an inhibitory subtype of G protein, which when activated, it inhibits adenylyl cyclase. When adenylyl cyclase is inhibited, you are not producing cyclic AMP. This histaminergic pathway is dependent on cyclic AMP. So if through the prostaglandin pathway, we are not having cyclic AMP, it means we have canceled this pathway. And therefore, acid secretion via this pathway cannot occur. That is how prostaglandins can help. Yeah, hello?
Can you take that again on adenylyl cyclase? I need some clarity because you mentioned that EP3 will give you the opposite effect of H2. That's not very clear. Please take that again.
Okay.
And also clarify what is opposing the histamine receptors.
Okay. So via the histaminergic pathway, we said that the H2 receptor subtype is coupled to the S-type G protein. That is the stimulatory type G protein. And when the H2 is stimulated by histamine, the stimulatory G protein will activate adenylyl cyclase. And adenylyl cyclase will produce cyclic AMP from ATP. And this will enhance acid secretion. That is how the histaminergic pathway acts. Now, let's go to the prostaglandin pathway. Prostaglandins act on their receptors, EP3. The EP3 receptor is also a G protein coupled receptor. By this time it is the inhibitory type of the G protein, not the stimulatory type, as how it is in the H2 pathway. The EP3 pathway, the receptor is coupled to the inhibitory G protein. When prostaglandins therefore stimulate their receptors, because of the inhibitory G protein, adenylyl cyclase this time is inhibited. Once you inhibit adenylyl cyclase, you are not producing cyclic AMP. And because this pathway is cyclic AMP dependent, and with the prostaglandin pathway, we are not having cyclic AMP. Histaminergic pathway if prostaglandins are around. This is how the histaminergic pathway is antagonized by prostaglandins. And therefore, one of the numerous functions of prostaglandins as key agents in defending the GIT. Please, are you okay?
Yes, please. Thank you.
All right. Now, so as I was saying, we have 3 different pathways through which acid is secreted, but they will all finally secrete the acid through the proton pump. So if we have a problem with acid, as we do in GIT problems like PUD, GERD, Zollinger-Ellison syndrome, why don't we minimize acid secretion? We can do that by, for example, blocking the acid leaves the parietal cell. In doing this, you are indirectly blocking all the 3 individual pathways. So by blocking this one point, you are blocking these 3 pathways of acid secretion. You can also decide to attack the 3 pathways independently. So you can have drugs or any strategy that will antagonize the histaminergic receptor competitively, or the CCK2 receptor, or doesn't can block internal pathway. If you decide not to block the receptors, you can block the signal transductions. A typical example is prostaglandins trying to block the signal transduction of the histaminergic route. So these are the means that acid will be secreted, and the means that we can block or minimize the acid secretion. Any queries? any queries before we continue? All right. Then let's consider the superficial epithelial cells. We said you can find them everywhere within the GIT. Their job is to secrete mucus and bicarbonate as part of the defense mechanisms. Here again, you can see the EP3 receptor on the superficial epithelial cells. The wonderful thing is that on the parietal cell, the EP3 is coupled to the inhibitory G protein. But on the superficial epithelial cells, the EP3 is coupled to the stimulatory type. And therefore, when prostaglandins are produced from arachidonic acid metabolism, or you give their mimetics as drugs, for example, misoprostol, they can act on the EP3 receptor, and since it is coupled to a stimulatory type of G protein, we are always going to have positive response. And the response includes secretion of mucus that physically form a barrier on the surface of the GIT and prevent direct contact with acids and other harmful agents like pepsin. And again, the release of bicarbonate, which in a neutralization reaction will neutralize the acid that will be secreted by the parietal cell. So we can draw a conclusion that even with this, prostaglandins are very important when you are considering the defense mechanisms of the GIT. Number one, it can minimize acid secretion by antagonizing the histaminergic pathway. 2, it can cause the secretion of mucus, protect the GI lining. 3, it can cause the release of bicarbonate, also neutralizing the excess acid. Again, protection. Not only that, as part of the physiological effect of prostaglandins, they cause vasodilatation. Of course, causing vasodilatation means that they can improve blood supply to the GIT. So even if you have an injury, wound healing process by way of natural cause would need adequate blood supply. You send more oxygen and nutrients there for the repair process. And therefore, anything that can cause vasodilatation can also help when it comes to wound healing. So prostaglandins, again, will give us that 4th benefit. Vasodilatation, improving blood supply, and therefore adequate wound healing. So prostaglandins, even from this diagram, it means that they are very important. So anything that will negatively affect prostaglandin synthesis, it means that we are not going to have all the functions. We cannot antagonize the histaminergic pathway. We are not going to secrete mucus. We are not secreting bicarbonate. And we are not sending enough blood to the GI mucosa. If you are not having all this, then the GIT is exposed. We can only suffer from injuries. So agents like NSAIDs, that will make sure that we don't get prostaglandins. Glucocorticoids, that will make sure that we won't get enough prostaglandins, are all enemies to the GIT. And that is why we implicate drugs such as NSAIDs and glucocorticoids in the pathophysiology of peptic ulcer disease. Again, the natural steroids that are produced in the body, cortisol, for example, through stressful conditions, can also have the same effect as glucocorticoids as drugs. And therefore, we can also implicate stress. Any condition that is stressful will cause the release of cortisol. And cortisol will also minimize arachidonic acid metabolism. If that happens via the inhibition of the COX pathway, we are not getting prostaglandins. So both stress, drugs like glucocorticoids, drugs like NSAIDs, will minimize or inhibit prostaglandins availability. With that, all the good things that we enjoy from prostaglandins, we are not going to get them. Then we are going to be exposed to the harmful effect of HCl and other harmful agents like pepsin and so on and so forth. So prostaglandins are key. We need them to be available so that we don't get peptic ulcer disease. Are we okay? So this is the way this diagram is trying to link all these processes to the development of ulcer. Once we understand this, then we are almost halfway through. The rest we just hit on it, then we go. Any queries before we move? Because this diagram is crucial to this topic. You accept that so that we don't get acid release. If you have H. pylori being present within the antrum of the stomach or the duodenum, is a bacterium, and therefore antibiotics or anti-infective agents can be used to kill H. pylori. You look at H. pylori. That's why you are seeing bismuth, metronidazole, tetracycline, clarithromycin, amoxicillin. Nowadays, the fluoroquinolones, levofloxacin, and so on and so forth, they can all kill H. pylori. So as it also use agents that behave like mucus. Sucralfate is here as a key example, so that it forms that structure, that barrier, just like mucus, and physically protects the GI lining from the acid. We can also give antacids that can come in and behave just like bicarbonate. So the magnesium trisilicate, that your aluminum, whatever, they are all going to mimic the effect of bicarbonate and therefore come in and neutralize. So you can see antacids neutralizing hydrogen ions that are released from the parietal cells. They are coming in to behave just like bicarbonate. Sucralfate and other agents that form barriers will come in and play the role of mucus. Artificial prostaglandin analogs like misoprostol can also come in and behave just like endogenous prostaglandins and play the role, give us all the functions. That is how come they can add misoprostol to diclofenac in Atrotec by way of protecting the GIT. So we know that the NSAID, diclofenac, is going to cause a reduction in the endogenous production of prostaglandins. We also want it to clear our pain for us. Okay, so we are taking it, knowing that by taking it, it will also negatively affect prostaglandins. We add a synthetic prostaglandin analog in misoprostol so that when NSAID, diclofenac, blocks endogenous prostaglandin, the artificial one that we have added will come and activate these EP3 receptors. And together with the vasodilatation effect, we protect the GIT. This strategy is referred to as cytoprotection. And you give a protective agent like misoprostol in addition to drugs that have the potential to minimize prostaglandin synthesis and therefore contribute to ulcer. We call it cytoprotection. So these strategies can be employed when we are trying to manage PUD. Any queries? Any queries? Class captain, can we continue? Can we continue? Are you there, class captain? Can you hear me? Anybody on the call, please respond so that I'll be sure. All right. Okay. So it means you don't have any issues. All right. Let's continue. So now quickly, I've already mentioned the defense mechanisms. So these mechanisms are there to protect the GIT lining from suffering from wounds, ulceration. So one of them is adequate mucosal blood flow, of course. prostaglandins will do that for us. Secretion of mucus. Yes, the mucus will form a barrier on the surface and protect us. Again, the various ions that can move from the lumen into the parietal cells. As an example, if you have calcium and the lining is open, the calcium can diffuse into the parietal cell and enhance the muscarinic and the direct gastrin pathway. With the barrier, you minimize the diffusion. You can see here that the proton pump, even the proton pump, before it can release the acid, there should be a potassium ready to be exchanged. So you can see the arrows. As hydrogen comes out, +1, a certain +1 must go in to maintain electrical neutrality within the cell so that there will be no chaos. If you allow the surface to be empty, that gives the chance for potassium to enter. By forming a barrier, you don't permit that. And with no potassium coming in, it will be difficult for hydrogen to come out. So the mucus, apart from forming that physical barrier to protect direct contact, it also slows ion diffusion. Here, calcium, potassium as examples. Calcium, potassium as examples. And of course, the harmful effect of macromolecules like pepsin. The lining also contains protein. And the moment pepsin gets in contact with the endothelium, it can also digest it and cause harm. So mucus, which is also under the control of prostaglandins, is part of the defense mechanisms. And of course, bicarbonate secretion. So all these defense mechanisms are principally controlled by the presence of prostaglandins. It means if you lose prostaglandins, we are losing these defense mechanisms. Then the GIT will be vulnerable to all those harmful or aggressive agents. What are these aggressive agents? Obviously, hydrochloric acid, pepsin, gastrin, and even bile acid. Bile acid, of course, is not that strongly acidic as compared to HCl, but it is still acidic. And when it is regurgitated into the duodenum or even the stomach, it can come in and add onto the acidic effect of HCl and still at least contribute something. So these are the common aggressive factors that can cause harm to the GIT. All right, now let's look at the root cause, the etiologies. H. pylori. We are going to handle H. pylori in detail. Then critical illness. I just mentioned that in critical illness, that is a stressful condition. You have stress hormones being released. As part of the stress hormones, you see cortisol. Cortisol is just like glucocorticoids. It's just like dexamethasone, prednisolone, and what have you. How do these corticosteroids contribute to peptic ulcer development? Of course, they can inhibit arachidonic acid metabolism and therefore minimize prostaglandins production. So all the benefits we enjoy from prostaglandins will be off. Not only that, they can cause G cells and parietal cells hyperplasia. Do you know what that means? It means you are going to produce excessive amount of gastrin and HCl. In doing that, they also diminish mucus synthesis and secretion. So all that corticosteroids are trying to do is to cause harm. They are only interested in things that can go against the GIT. 1, they are inhibiting prostaglandins production. 2, enhancing gastrin and parietal cell hyperplasia. So you are producing more gastrin from the G cells and more HCl from the parietal cell. Then on the superficial epithelial cells, they diminish mucus synthesis and therefore mucus secretion. That is how critical illness contribute to ulcer development. So you have stress-related mucosal damage. Stress-related mucosal damage. In the ICU, because of this, we do a routine prophylaxis against ulcer. So as part of the ICU routine medications, you would normally see a proton pump inhibitor or an H2 receptor antagonist as part of the routine medications of the patient. Stress. Once you are critically ill, is stress. And critical illness could be anything. Any condition when it becomes critical is critical illness. Which means that drugs, the so-called glucocorticoids, will also have the same mechanism. They also utilize the same mechanism. So glucocorticoids will also utilize the same mechanism and contribute to ulcer. NCA enzyme, and therefore we are not producing prostaglandins. You have to start destroying your own cells with chemotherapeutic agents. Cancer cells are part of our own cells. Just that they have decided to misbehave and overgrow. That's the only difference between normal cells and cancerous cells. And in fact, chemotherapeutic agents will utilize that to a larger extent, destroy cancerous cells and relatively cause less harm to intact cells. So the unfortunate thing is that the only way that chemical rate of proliferation, it means that if you are even a normal cell, you are not cancerous, but naturally you grow faster, then chemotherapies will also target you. Because the only way they can differentiate between normal cells and cancerous cells, and therefore attack cancerous cells more and leave normal cells, is the rate of proliferation. Those who grow faster, chemotherapies will target them and kill them, as compared to those with normal growth. And therefore, normal cells with natural proliferative rate, faster proliferative rate, will also suffer. So it's not surprising that fast-growing cells like your hair, you become Sakura if you are put on some chemotherapies. Because you shave your head today, then in the GIT, they have a very fast turnover rate, so they also grow faster. It means when you are on chemotherapy, these cells are also going to be attacked, and that is what gives rise to the ulcer, chemotherapy-induced ulcer. So you have some people on some chemotherapeutic agent, and they complain of ulcer. We confirm, and then we see that they are having ulcer. It is because that chemotherapeutic agent can no longer differentiate between the GI lining cells and the cancerous cells, because they are both fast-growing cells, and therefore that agent will attack them squarely. So this is how chemotherapeutic agents contribute to ulcer. They attack every fast-growing cells. You even get anemia. You get anemia from chemotherapy, and you are put on EPO. Why? Because red blood cells are part of the cells with high turnover rate, and therefore equally, as I've discussed for GI lining and cancerous cells, red blood cells will also be attacked. Then you get anemia. So you see, mostly cancer patients will present with anemia when we put them on chemotherapy. This is how chemotherapy contributes. It's the same way radiotherapy, which is another strategy to kill cancerous cells, will also cause peptic ulcer. So when you see, radiation is here. So it's the same way. Radiation will pick on every fast-growing cell. So red blood cells, so the GI lining, cancerous cells. So radiation can also contribute to ulcer. If you get gastrinomas, that leads to hypersecretion of acids, Zollinger-Ellison syndrome. can also contribute to ulcer formation. If you smoke for effective wound healing, in case you even get any ulceration, the healing process demands that you supply more blood, which will provide nutrient and oxygen for wound healing. Nicotine is a vasoconstrictor, and therefore it will minimize blood flow to the GI mucosa. It also inhibits prostaglandin synthesis and can contribute to bile acid regurgitation. Remember, we implicated bile acid as one of the aggressive factors. So if nicotine coming from cigarette is going to cause backflow of bile acid, that is bile acid regurgitation, then it may also contribute to ulcer. Hello, please, can you hear me?
Yes, please, sir.
All right. So alcohol can also, in a way, contribute to PUD. How? It causes irritation. Some alcohols are too strong. So locally, it can cause irritation and weaken the GI mucosa. That can lead to inflammation. Obviously, once you have inflammation, it can predispose you to ulcer formation. Crohn's disease. So that BID and those things. So that one too is an inflammatory condition of the GIT. That one can also give you ulceration. Viral infections. Infections can lead to inflammation. For example, cytomegalovirus infections. That one can also put you at risk of ulcer. At times, none of the above will be there, yet ulcer is present. So it means that you are an idiot. You cannot find the underlying cause. How can you be suffering from something and they ask you and you are saying you don't know how? It means you are an idiot. Hence the term idiopathic. You are an idiot for not knowing why you are suffering from PUD. You've checked all these parameters, none is there. The problem is there. So there should be another underlying cause. However, you've checked, confirmed, second check, third check, and none of these issues are there. Once it is there, there should be an underlying cause. And if you can't tell us, then they say that you are an idiot. Hence the term idiopathic cause of ulcer. It means you can't tell us. Class captain, are we okay? Are we okay? Any queries? Any queries? Please, can we continue? Hello?
Hello, sir. Yes, please, sir.
Yes, please, we can continue.
All right. Now, let's look at this guy. You mentioned it as the first culprit, but I did not talk about it. H. pylori, a gram-negative bacillus, found principally in the antrum of the stomach, a very stubborn guy. This area is full of acid, hostile environment, yet it survives. Most bacteria will die there, but this guy is always surviving. And when it survives, it's an infectious agent, so it can cause inflammation, just like the viral infections, and give us ulcer. How? How is it able to survive and cause harm to us? Because it has some virulence factors, mechanisms that it utilizes to survive and cause harm. For any organism to establish any infection or any problem, number one, that organism must be able to survive the host defense mechanisms. And after that, should have some mechanism in place to cause harm. If you can only survive, but you can't cause harm, then you are not a pathogen. You can stay in the body and we will mind you because you can't cause harm. Those that are able to survive the host inflammatory mechanisms and in addition cause harm, they are the pathogens. H. pylori is one of them, and they are said to possess virulence factors. Let's look at the virulence mechanisms of H. pylori. To survive, it has a special enzyme called urease. Urease, as the name suggests, the way we name enzymes, We can name enzymes based on the substrate they act on. So if you act on bobo, we can call you as bobis, an enzyme that acts on bobo, bobis. If you act on urea, as in the case of urease, then we call you urease. So urease comes from H. pylori. And when H. pylori secretes urease as part of its mechanism to survive, it breaks down urea into carbon dioxide and ammonia. Ammonia is a basic agent. With a base around, it can neutralize the acid around the vicinity of H. pylori so that the acid cannot kill it. We just claim that the acid is one of the defense mechanisms by way of our immune system. It protects us from infectious agents. H. pylori is an infectious agent. Why is it able to survive? It is because H. pylori have this in place to neutralize the acid. Very bad guy. Again, after it's managed to survive, then it can cause harm. It has the capacity to cause harm, and this harm is inflammation. Why? Because it has the capacity to release certain toxins. For example, the cytotoxin-associated gene A and the vacuolating cytotoxin A. These toxins can cause mucosal inflammation and therefore cause damage to the GI lining. So it will survive by using the urease and through bombs, through missiles. The missiles include the CAC-A and the VAC-A. Interestingly, it won't stay at one place and cause harm. It has the means to move around. So after destroying one area, for example, the stomach, it can also move because it has what? Flagella to move around. So it can also move to the duodenum and cause same havoc there. So by the presence of urease, the toxins, and mechanisms for movement, H. pylori can survive, cause harm to numerous areas, notably within the stomach and the duodenum, contributing to both duodenal and gastric ulcer. Very stubborn guy. Any queries? And therefore, if we are managing H. pylori or we are managing peptic ulcer, it is important that we check for the presence of H. pylori, and if it is there, we destroy it, because independently it can cause ulcer. Together with other aggressive factors, the situation becomes worse. So it is important that we detect the presence of H. pylori when we suspect or confirm peptic ulcer disease, and if it is there, we use aggressive means to kill it. If not, we are not going to be successful. Vice Captain, can we continue? Can we continue? Any queries? Please, I need feedback from you. Any queries? If there are no questions, at least one response or something so that I can continue.
No question.
All right. Thank you very much. So now, let's look at how PUD is classified based on the root cause. So normally, based on the etiology, the most common ones that we know, either H. pylori induced, the most common ones. We implicated so many things, but the first three most common causes: H. pylori induced, NSAIDs induced, and then stress-related mucosal damage. That is stress ulcers, stress-related mucosal damage. This is how commonly we classify ulcers based on the etiology. We are using the first three most common causes. So normally in H. pylori and NSAID induced, it is by way of chronicity, but stressful ones are just within that stressful period. So it's always described as an acute. It's not a chronic situation. But H. pylori chronic infection, NSAIDs will be a long-term use, not just 1 day, 2 days, or 1 week use of NSAID, then you get ulcer. So by way of differentiation, H. pylori and NSAID induced are said to be chronic, while stress-related mucosal damage acute. Then common sites where these problems normally occur. Remember, we are talking about duodenum and stomach. So for H. pylori, it's more common within the duodenum than the stomach. But for NSAIDs and stress, more common in the stomach than the duodenum. More common, of course. H. pylori, yes, it has the defense mechanisms, but it prefers compared to the duodenum. So you have more and more H. pylori. So if you are considering the involvement of H. pylori in duodenal versus gastric ulcers, you realize that a higher percentage of duodenal ulcers will come with H. pylori positive test as compared to the stomach one, meaning that yes, H. pylori, it loves the stomach. It loves the duodenum because that place is less hostile. It is less acidic. Now, is it pH dependent or not? That is acid dependent or not? If you have H. pylori and you have more acids, then it becomes combined problems. So two independent risk factors. So it will be worse. The others are normally less dependent on acids. They are normally less dependent on acids. How about the symptoms? H. pylori, usually epigastric.
I didn't get the H. pylori and the acid dependency part.
Yeah, so the acid is an independent contributor when you are talking about PUD. H. pylori too is what? An independent contributor. So the moment you have acid and you have H. pylori, then it's worse. So yes, H. pylori can do the work, neat. But when it gets help from acid, so in addition to acids, then you are dead. So if you are talking about the contribution of acids in the presence of these three separate etiologies, if you have acid in the presence of H. pylori, then you are dead. The rest on their own, they don't normally depend on it. They use their mechanism of actions to contribute to PUD, not necessarily depending on the input from HCl. Then the symptoms, H. pylori induced, normally the patient will complain more of epigastric pain. NSAIDs and stress, they may not even complain of any pain, yet the ulcer will be there. The ulcer will be there. So the two may be asymptomatic, but with H. pylori, the patient normally complains of epigastric pain. H. pylori wounds normally is deeper. It can extend all the way to the muscularis. The other two are normally superficial. And stress ulcers normally bleeds a lot. In the acute phase, patient is already exhausted, lose mechanisms, protective mechanisms. At that point, you remember yesterday, critical illness, thrombocytopenia may be there, and therefore, the moment you begin to bleed, your coagulatory pathways may be compromised. So in terms of stress, you are more likely to bleed. Yesterday, we discussed that. We said during critical illness, there is thrombocytopenia, and your coagulation factors are compromised. When we're talking about the non-autoimmune hemolytic anemia. All right.
And you are saying the H. pylori is acid dependent. It likes acid, but in its virulence, you said it has UAs which neutralize the acid. So I'm confused. If it likes the acid, why does it have to neutralize it?
No. As an agent, it doesn't like acid. But when it comes to causing the problem, it does it very well when acid is around, because acid is an independent risk factor and H. pylori too is an independent. So it's like communal labor. I don't like you, but you do what I do. So if I survive and you're also around, my work becomes more easier. Are you okay?
Yes, please, I'm okay. Thank you.
All right. Okay. All right. So as I was saying, stress-related mucosal damage the patient normally bleeds a lot as compared to the other two. Why? Because if you can remember yesterday, we said during critical illness, the patient, for example, may suffer from MAHES, the microangiopathic hemolytic anemias. You remember, we said at that point, we have coagulopathies. You have increased INR, reduced or increased bleeding time, reduced fibrinogen, increased prothrombin time, all those things with thrombocytopenia. So it means that your coagulation is impaired, and therefore when you begin to bleed, you are not going to stop anytime soon under stress-related ulcer. So this explains why you are seeing that bleeding when it comes to stress-related mucosal damage is seen as more severe as compared to the NSAID-induced and H. pylori-induced. Under stressful conditions, you are having coagulopathies already. And therefore, when bleeding starts, you find it very difficult to clot and you bleed excessively. That is why bleeding in stress-induced is more severe than the remaining two. Any queries again? So this is by way of classifying the PUD by etiologies. Now, we can also classify it based on where the problem is. That is anatomical classification, whether it's occurring in the stomach or the duodenum, whether it's occurring in the stomach. So as I said, you can see H. pylori be involved in relatively higher percentages in duodenal ulcers as compared to gastric. Gastric 60 to 85, duodenal almost 100%. So almost 90 to 100% of duodenal ulcer patients would also present with pyloric infections, H. pylori infections, while 60 to 85% will have H. pylori infections. In duodenal ones, you would have hypersecretions as well. As I said, when H. pylori is there and it sees that ACL2 is there causing its own harm, then it will be happy. So you see that there is normally hypersecretion in duodenal ulcers where H. pylori is there as compared to the gastric ones. Interestingly, with the stomach one, when you eat, you feel pains. So maybe once you have the ulcer in your stomach, you take in the contour, and it goes in there and scratches the surface of the wound. Maybe then you feel the pain. Maybe that is the issue. They advise that you eat small stuff. Don't eat volumes so that it begins to stretch your stomach and cause more harm. So once you eat and you feel pain, a person wouldn't like to eat in gastric ulcers. Stomach ulcers, if I eat and it comes with pain, then I won't find it comfortable to eat. And therefore, you see these individuals growing lean on my phone. Because if I'm going to eat and I'll feel pain, would you be happy when they give you food? No. But with duodenal ulcers, you realize that when you eat, the pain subsides. And therefore, these individuals are always eating. You see them bloating, growing fat. And the pain normally comes at night. So even at night time, they wake up and eat. When they are coming for lectures, they are going for ward rounds. They have bread in their bags. So 1, 2, 3, as if they are going to look at something, they will go and then take a bite of the bread. 2, 3 days, you see them becoming fat. That is duodenal ulcers. Gastric ulcers, normally they grow lean because when they eat, they feel pain. Gastric ulcers are less likely to bleed as compared to duodenal ulcers. By way of age distributions, gastric ulcers relatively affect the aged, the grown-ups, as compared to duodenal. So 40 to 70 years for gastric, 30 to 55 years. That age group, you realize that they present with duodenal ulcers. By way of sex distributions, more females are seen to present with gastric as compared to males who would normally present with duodenal ulcers. Duodenal ulcers have a lot of H. pylori. How do we get H. pylori? Similar to the way we get typhoid fever, connected to hygiene. Females and males, hygiene. Males, diarrhea. Males, diarrhea. And therefore, it's not surprising that more males, if the root cause is similar to that of typhoid fever, and typhoid fever is connected to hygiene. Females and males. Females are better than us. This one I've admitted, accepted. And therefore, it's not surprising. So don't be surprised that more males will present with duodenal ulcers. Duodenal ulcers with 90 to 100% H. pylori, hygiene. If hygiene, females will do better. And therefore, more males will obviously present with duodenal ulcers compared to females. Class captain, are we okay? Any queries? Any queries? Can I
Please, can you take it again? The line was breaking.
Oh, okay. So I was trying to link this epidemiological stuff. A statement that females do present with more gastric ulcers and their male counterparts will present with more duodenal. It is known that H. pylori is more common with duodenal. And now we are saying males too will present with more of duodenal. Now, how do we get H. pylori infections? The same route as typhoid fever, which is linked to hygiene. Obviously, the moment you mention hygiene, males we born, because we know that you females are better than us. And therefore, if the infection, which contribute to a higher percent, all the way up to 100%, will present with duodenal ulcers, and males, we have issues with hygiene, then it is more likely that we will present with duodenal ulcers as compared to females. So it's not surprising to see more males presenting with duodenal ulcers because it has a link. Hygiene has a link with H. pylori infections, and H. pylori infections are seen in more and more patients with duodenal. What do you expect? You expect more males to present with duodenal ulcers as compared to females. Please, are you okay? Lana, is that Lana?
Please, I'm okay. No.
This is not Lana. You have a similar voice. What's your name? Hello?
Mildred.
Mildred. Oh, Mildred. Mildred, yes. Yes. I had a chat with you today. All right. Okay.
Yeah.
Now, the risk factors and the etiologies again. Yeah. So all these ones, we've mentioned them. So H. pylori infections, critical illness, nicotine from cigarettes, NSAID, aspirin. Then, some of these drugs will not directly cause ulcer. They may not directly cause ulcer. But when you have ulcer, they may increase your chances of bleeding, some of them. So let's look at them. Of course, anticoagulants, antiplatelets, their main problem is what? Bleeding. So if you have ulcer and you are on these drugs, you are likely to bleed. Bisphosphonates, drugs that we use in the management of osteoporosis. Bisphosphonates, alendronate, etidronate, those drugs. They can cause irritation of the GIT. Once you irritate the GIT, you may contribute to ulcer. KCl, you remember the exchange between potassium and hydrogen. So that is that. So potassium must go in. That's more or less like an antiport system. Potassium goes in before hydrogen comes out. So you must have potassium. So the moment you are making potassium available in the stomach or in the body, and it can obviously exchange with hydrogen, that could also be implicated. So KCl as a drug, if you swallow it or whatever, it can also improve acid secretion. The proton pump exchanges potassium for hydrogen. Then the selective serotonin receptor uptake inhibitors. Selective serotonin uptake inhibitors, SSRIs. One of their side effects is platelet aggregation inhibition, not platelet aggregation. They inhibit platelet aggregation. If you inhibit platelet aggregation, then you are more or less like anti-platelet. You are more or less like anti-platelet. So you can increase the chances of ulcers, bleeding. Glucocorticoids, we know them. Dietary factors can also contribute. So diet that contains too much spices, those ones, peppers and onions, and even the artificial ones, gingers, what have you, they can also either worsen or contribute in a way to the development of PUD. And therefore, by way of counseling, you may have to hit on some of these issues and advise the patient accordingly. Now, NSAID, very important. NSAID, very important. Now, in general, for NSAIDs to induce, that is their mechanism of action. So that one, there is nothing you can do unless you decide not to take or you do cytoprotection. So the moment you take NSAIDs and you want NSAIDs to work, they work by blocking cyclooxygenase. That is how they work. And once they work that way, you are going to have reduced prostaglandin synthesis. Yes, that can cause ulcer. But if you have at least certain risk factors, then your chances of getting NSAID-induced ulcers will be high. For example, if you are very old, of course, as you age, so many things within your body turns around and goes bad. So age above 65 years is a high risk factor. If you use high dose, you can use NSAIDs, but the problem is possibly a dose dependent. So if you use like maximum doses, especially for longer periods, then that will also be a risk factor for NSAID-induced ulcers. If you already have a history of ulcer, you are an ulcer patient, and you are going to take NSAIDs, of course, that's another risk factor. If you are on NSAIDs and maybe you are doing secondary prevention of any cardiovascular condition, and therefore you are on aspirin as an antiplatelet agent, aspirin too will inhibit the cyclooxygenase enzyme and therefore contribute to the inhibition of the prostaglandins production. So if you are taking an NSAID and you are also doing secondary prevention of cardiovascular events with any aspirin, that is also another risk factor for an NSAID induced. So as I said, between the presence of HCl and H. pylori, it becomes like a communal labor. With aspirin plus NSAIDs, two independent risk factors coming together, the job becomes easy. So old age above 65, high dose NSAIDs, history of uncomplicated ulcer, and concurrent use of aspirin are all risk factors for NSAID-induced ulcers. Among these, we have low risk, high risk, and moderate risk if you are talking about NSAID-induced ulcers. It is classified into three types: low risk, moderate risk, and high risk. For low risk, it means you are on NSAID, but you don't have any of these risk factors. Your age is less than 65. You are not taking high-dose NSAIDs. You don't have a history of uncomplicated ulcer. Neither are you on baby aspirin for cardiovascular secondary prevention. In that case, if you are on NSAID, the chances of the NSAID giving you ulcer is very low. So low risk. Then we have moderate risk. So moderate risk is when you are on NSAIDs and you have one or two of the risk factors. So if you have one or two of the risk factors and you are on NSAIDs, you stand at a moderate risk. Then high risk is when you are on NSAIDs and then you have more than 2, you have at least 3 of these mentioned risk factors for NSAIDs-induced ulcers, then you are in trouble. Red flag, high risk, high risk. So this is how those on NSAIDs, if you are assessing your chances of getting ulcers, this is how we classify you: low risk, moderate risk, and high risk. Now, for this, NSAIDs themselves, we say they have the inherent capacity to cause ulcers by way of their mechanism of actions. They've been classified into 3 based on how risky they are. The classification differs among US and UK literature. There are some issues with them, the way they put some drugs in certain levels. But with high risks, normally these drugs, be it US or UK, they all classify them as high risk. So Piroxicam, locally known as PAOPA. So if you are on PAOPA, Piroxicam, it's a high risk. Indomethacin, Acocrabe. Indomethacin. Nowadays, they don't even buy it for pain. They buy it to kill Nkra. They buy it to kill Ekra because the indomethacin can cause massive ulcer in the GIT of the Ekra, and the Ekra will get active peptic ulcer and die. So when they come, they say, oh, Ekra be hammer, me Acocrabe bobo. They go and then pour it on some bread or some fish or something. Then the Ekra will go and eat, get ulcer and die. Then ketorolac. These 3 are considered high-risk NSAIDs in terms of the ability to cause ulcers. Moderate risk, the UK literature will classify naproxen and diclofenac as moderate risk, but the US literature only states naproxen and rather put diclofenac at low risk. But with your exam, your exam, that is GPQ, they consider BNF recommendations, that is UK, because we are more of UK inclined. So if they ask you of moderate NSAIDs with moderate, please, in the exam, put diclofenac at moderate risk. This is a US classification. So moderate risk, UK guidelines, naproxen, diclofenac. US guidelines will say diclofenac is low risk. Low risk, ibuprofen, very friendly. Ibuprofen, very, very friendly. Then nabumetone is also considered as low risk. Any queries? Any queries? The pathophysiology is very simple. Remember the defense mechanisms versus the aggressive factors. Anytime that the aggressive factors override the defense mechanisms, that is ulcer for you. Very, very simple. Defense mechanisms succumbing to aggressive mechanisms, that is ulcer. That is the pathophysiology. Very simple. Of course, it will lead to mucosal damage, and that is what we refer to as ulcer. Ulcer complications. You could have upper GI bleeding. Yes, the bleeding could be secret, that is occult bleeding. You are bleeding, but you can't see it. Or overt. Overt. So in overt bleeding, it may appear as hemetemesis. You vomit blood. You vomit blood. Or it will appear as dark stools, melena. If you overbleed, you are losing blood, you get hypovolumic shock, hypotension, you may not survive. You may die. So hypovolumic shock, excessive bleeding through massive ulceration, active peptic ulcer disease can be the final or the ultimate result. You can even get perforations. As I said, the depth of the wound can be so deep such that it can even run through the entire depth of the GIT. Then you get perforations. And this normally happens in about 7% of patients with PUD. Some of them too can get GI obstructions. Some of them can get GI obstructions. Why? Because you get repeated ulcerations, it heals, then you get obstructions. At times too, when the wound is there, there is edema, and all of these can block your GIT and give rise to obstructions. In case of obstructions, these are normally the signs and symptoms that the patient will present with. Early satiety. You eat something small, the fufu is there. If you calculate, you can take 20 contomwa, but you take just 3 contomwa and you feel like you are full. Very sad. Ulcer can do that to you. Small food, you grow lean. Small food. Ultimately, if all these things are happening, you are going to lose weight. You can't eat. You are vomiting. You are losing fluid. You know your body water. Water as an adult will cover about 60% of your body weight. So if you are not putting in enough and you are also vomiting, you become dehydrated. You lose weight. You are not eating well. You take this 3 shots, you are full. You can't eat. You eat and you feel pains. For gastric ulcers, you are not putting in enough nutrients. You lose weight. You grow lean. Basa. Malnutrition will set in. So these are the complications of peptic ulcer disease. Signs and symptoms. Epigastric pain. Yes, normally described as burning pain. You may feel cramps, early satiety, fullness, night pain, especially the duodenal ones, night pains. Normally, it may even come with signs and symptoms of GERD as well. So heartburns, belching, bloating. By this time, it will come with epigastric pain. Then you feel, of course, nausea, vomiting, and anorexia. Ultimately, you are going to lose weight. If perforations gets to where you damage your blood vessels, you bleed. And obstructions, as mentioned already, you can get obstructions by repeated ulcerations, scarring formations, and edema during inflammations. So these are normally the lower ones are the alarming signs. When it gets to the stage where you are showing signs of the complications, then it becomes an alarming sign. Class captain, what says the time? What says the time? Hello?
Hello, sir.
5:11, 5:14.
Oh, okay. We have more time. So now, this guy, H. pylori, we will come to how you confirm the ulcer proper. But if you want to treat peptic ulcer appropriately, once you find out that the ulcer is there, of course, you use patient history and everything to try and then confirm possible underlying causes. You must go after this guy. And if it is there, you must clear it. Because remember, in gastric, we are having at least 60% of patients having it. In duodenal, at least 90%. So it means this guy is very, very common. And therefore, once ulcer is confirmed or is suspected, you can do tests to confirm its presence so that you can include it in your strategies when you are managing the peptic ulcer. To identify it, we have 2 basic strategies: the invasive strategies and the non-invasive strategies. So let's look at the invasive strategies to try and then identify H. pylori. The invasive ones, it means that you are entering the body. If you say invasive, this procedure is invasive, of course, you understand. So by way of histology, so histology means that we are going to take certain tissues. Then we observe them under the microscope after staining them to see if we can detect H. pylori. So we go in there, of course, with a scope, then we take tissues, so histology. Then you bring it to the microbiology lab. You bring the tissues to the microbiology lab, you add some stains to it and see if you can find H. pylori. The microbiologist will have some characteristics that they will use to identify H. pylori. It's very sensitive, 90 to 95% sensitive, and as high as 98 to 99% specificity. And of course, if you are going to take biopsy, it must comes with high skill, else your sampling may be faulty. You may take it from where maybe H. pylori is there, but you took it from somewhere. So knowing that it is highly available within the antrum, it means that you have to take the samples from the antrum rather than from areas like the corpus or the fundus. If you take the tissues from the fundus or the corpus, you may come back and see nothing. Then you say that it is negative. That may be false negative. So sampling technique is very, very important. If you're able to do it well, it is highly specific and highly sensitive. You can also do culture. So again, you take a biopsy, then within the microbial lab, you culture it. If H. pylori is there, it will grow. So you culture it through your differential medium. Then the microbiologist will give you the results. Oh, H. pylori is not there, or H. pylori is there. This one is 100% specific. If it is there, it is there, because you are going to culture it. So the microbiologist will do that. Then we have the CLO test, the Compactobacter-like organisms test. So that one too will utilize biopsy. It will utilize biopsy. But again, it is going to utilize the principles of the urease enzyme. Now, you go in there and then you pick tissues, you pick biopsies from the antrum. So you bring the biopsies and then you add urease, a urea containing reagent to the biopsy. I repeat, it's an invasive procedure. So you take biopsies in the antrum where you have H. pylori. So when you bring the biopsy, you add a reagent that contains urease. Or you add, urea rather. Yes, you add a reagent that contains urea. And then you are looking for H. pylori in the antrum. So you pick a biopsy from the antrum. If H. pylori is indeed available within the biopsy that you have taken, the moment you add the reagent that contains the urea, it means the H. pylori will release urease and break down the urease into carbon dioxide and ammonia. So if indeed the biopsy that you have taken from the person's antrum contains H. pylori, you add a reagent that contains urea. The moment you add it, the H. pylori will release urease. It will act on the reagent that contains urea and break it down to carbon dioxide and ammonia. Once the ammonia is produced, the reagent will show a color change. And a positive test is when it changes from yellow to purple. So the presence or the production of ammonia from the H. pylori releasing the urease will cause this color change from yellow to purple. So that will prove to you that, then the biopsy that you took contains H. pylori, because it is H. pylori that will release urease. For the urease to act on the reagent that contains urea, break it down to produce ammonia and carbon dioxide. And in the presence of the basic ammonia, the reagent will change color from positive test, as in from yellow to purple, as a positive test. But there could be some interference, especially if you have any situation that can kill or that can minimize the population of the H. pylori before the test. So imagine it's just like when you are doing any treatment, you are going to test for malaria and you have already taken anti-malaria about 2 or 3 days before the test. You go there and it will be negative. That doesn't mean that you didn't have malaria. It is because you have taken anti-malarials to kill the parasite before coming for the test. So if you are on agents like antibiotics that can kill H. pylori, PPIs, bismuth, H2 receptor antagonists, or even if you have a chlorhydria, it can affect or interfere with these results and give you false negative results. And therefore, it is advised that if you are on any of these agents, especially the antibiotics or the acid secreting agent, you must wait. You must wait for the anti-secretory agent. If you are on them, stop taking them a week prior to the test. Antibiotics about 2 weeks prior to the test, so that it will not interfere with the results. So these are the invasive tests. The name Campylobacter-like organism, it stems from the previous name of H. pylori. Previously, we used to call it Campylobacter pylori. Then recently, they changed the name from Campylobacter to this H. pylori, Helicobacter pylori. The previous name was Campylobacter pylori. So this test is named after it, Campylobacter-like organism test. Take a biopsy from the antrum. You add a reagent containing urea. Urease, if indeed H. pylori is there, will convert the urea, that is the reagent, to ammonia and carbon dioxide. This will cause a color change from yellow to purple, indicating that urea has produced the basic agent ammonia. This can happen only when H. pylori is around and it releases urease, positive test. However, certain inputs can interfere. Anti-secretory agent, anti-infectant is not on this before you do the test. How about the non-invasive ones? You can do antibody test. So once you have a foreign agent in your body, you always mount an immune response, provided you are immunocompetent. Once you are immunocompetent, you mount an immune response. Any foreign agent, especially infectious agent, pathogens. So antibodies like immunoglobulin G antibodies against H. pylori could be detected in the blood. This to reduce the populations that will avidly stimulate the production of antibodies. This one is 85% sensitive, 79% specific. Then the ultimate, the gold standard. The
Hello,
gold standard.
Doc. Please, can you
Yeah,
repeat the antibody detection?
Yes, you have an infection. If you are immunocompetent, your body will produce antibodies against that infection. And therefore, if you have an H. pylori infection and you are immunocompetent, your body will produce this immunoglobulin G antibodies against H. pylori. Then through serology, you detect it. So the serologist will collect your blood samples and do his tricks. And if he detects immunoglobulin G, it is said to be 85% sensitive and 79% specific. So it means that, yes, you can still show positive to this immunoglobulin G, but 21% of those who shows positive test to these antibodies may still not have the infection. That is what we mean by the specificity. It may be due to another infections, not necessarily H. pylori. But as high as 79% of those who test positive for this immunoglobulin G, normally it is H. pylori, 79% out of 100. But 21% will show positive test, but still it will not be because that they have H. pylori infections. Are you okay?
Yes, please.
All right. Then the ultimate, the gold standard, considering whether invasive or non-invasive, all the strategies that we use to test the presence of H. pylori. The ultimate is the carbon-13 urea breath test. Of course, being non-invasive, you are not going to cause much harm to the patient. This is 97% sensitive, 95% specific. This is very, very important. Now, the interesting thing is that you can use it for two things, both for diagnosis and both to monitor for response to treatment. So you can use this one to detect whether the problem is there or not. And after you clean that, with taking your medications to clear it, you can repeat it to confirm if indeed you have eradicated H. pylori. It is the gold standard. So this is how it is done. So they give you a certain capsule to swallow that contains a carbon labeled urea. You know urea, the formula for urea. Urea is a combination of two molecules of ammonia and carbon dioxide. So the carbonyl carbon, the C there, is labeled like a radioisotope. It's labeled. So we have marked it so that when we see it sometime, you know that, oh, this is coming from the urea. So you give a capsule containing a labeled carbon urea for the patient to swallow. The moment this is swallowed, it gets to the stomach. If H. pylori is there, it will release urease, and urease will act on that labeled carbon urea and break it to carbon dioxide and ammonia again. So the carbon of the carbon dioxide will be having the labeled carbon, and carbon dioxide is a gas. So the moment you breathe out it to a certain machine, that labeled carbon from the carbon dioxide produced from that reaction, urease breaking down urea, will be detected, and that will confirm that, oh, H. pylori is down there. That is why our labeled carbon in the urea is coming out with the carbon dioxide. This is a gold standard test for H. pylori. Non-invasive, very, very sensitive and specific. 97% sensitivity, 95% specific. Here again, it can be interfered by PPIs, anti-secretory agents, other ones like H2 receptor antagonists, and antibiotics. We need the H. pylori to be active, there, alive, so that it will give us the urease. If you kill it before by taking antibiotics, for example, you will kill everything and the H. pylori will not be there to release the urease. The test will come out negative, meaning you have never had an infection. Meanwhile, it was there. So you need to what? Make sure that you hold your antibiotics for 2 weeks, as well as your anti-secretory agent, prior to the test. Prior to the test, you have to do that. Yes, else it will interfere with the results. Another and the last invasive test is the serology test. Stool antigen. So if you have H. pylori in the stomach or the duodenum, the antigens or certain markers on their body could be part of your feces. That one, feely. If H. pylori is not there, you are not getting its markers in the feces. So the moment you do the stool antigen test and you detect antigens in the patient's stools, antigens that are serving as markers to H. pylori in the person's stool, then it means that H. pylori is in the person's stomach or duodenum, and that is a confirmation that the infection is there. Putting everything together, always remember that the carbon-13 urea breath test is the gold standard to detect H. pylori infections. We are after this because it is very harmful when you are considering peptic ulcer disease, and therefore its detection is crucial. If you, as in, survive or not survive, or if you be successful or not successful when you are managing peptic ulcer disease. If it is there, you clear it with the appropriate antibiotic regimen. If it's not there, fine, then you only focus on other measures that can be used to manage peptic ulcer disease. Now, a confirmation of the disease itself. You can use radiography or endoscopy. Normally, if the complaints, signs and symptoms doesn't depict complicated ones, it is better you do radiography. That is X-ray with barium contrast. That is not invasive. So if the thing is uncomplicated, it's necessary for you to be doing invasive approach to cause unnecessary inconvenience to the patient. If the signs and symptoms depict uncomplicated one, why do you go all out and choose an invasive procedure like endoscopy? So with that, you just do barium contrast radiography. So the contrast, if the ulcer is there, will paint. And then when you take the X-ray shots, it will depict. However, the resolution or the confidence with which you can say that it is there or not is not the same as when you are doing endoscopy. But when the patient presents with a more complicated signs and symptoms, then you go by upper GI endoscopy, where they pass a certain flexible tube with some scope, a camera at the tip. Then they push it down your esophagus into the stomach and the duodenum. And then it will be displayed, captured on a screen and printed. Then the gastroenterologist will now see the thing feely, whether the source, the craters are there or not. This will confirm the presence of the ulcer or not. Then you go and find possible etiologies, drug histories, family histories, social histories, nicotine and those things, drug histories, NSAIDs, glucocorticoids, medical history, stress and those things. And then H. pylori test, you do it. You are just trying to find the underlying cause so that you direct the treatments towards clearing these etiologies. This is how PUD is diagnosed. Any queries? Any queries? Any queries? Please, can we continue if there are no queries?
Please, can you repeat the endoscopy part again?
Yeah, so endoscopy, a flexible tube that has some camera at the tip. Under sedation, of course, they are going to put it through your, it's invasive, so it's not that comfortable. So you'll be sedated. Normally they use propofol, some small dose so that you are lightly sedated. Still, you are going to feel some inconvenience. So they pass that tube through your mouth, down your esophagus, push it down, they reach the stomach, then the thing will be shown on the monitor. The system will capture it. They push it deeper again to the duodenum, trying to locate the presence of ulcer or damages there. So that one, the gastroenterologist will see it, feely, whether there are sores or not. And that will confirm the presence of the ulcer. After this, you have to treat. If you are treating, then you have to target the underlying cause, the etiology. How do you do that? You start from gathering history. So social history. Does this guy drink alcohol? Does he smoke? All these things must be stopped. Even eating habit. What type of food does he eat? Medication history. Is he on any aspirin, NSAIDs, glucocorticoids? Anything that can contribute to ulcer, food, whatever. You do all those things. Then you try and then determine if H. pylori is there or not. Probably the gold standard test, the carbon-13 urea breath test, so that if it is there, you can do. At times you can have multiple risk factors. So the ones that you can just clear by advising the patient to stop having contact, you address. So if it's smoking, gentlemen, cease smoking. If it's alcohol, not stop entirely, but take it in moderation. Smoking is cease. Alcohol, take it in moderation, unless there is liver disease. If the person doesn't eat well, it's from his eating habits, you advise. Anything that can be addressed through counseling, you do that. If it's drug, stop and those things. If it is H. pylori, is a bacterium, and therefore you must know that you add antibiotics, appropriate antibiotics that can kill. You add it. Then the appropriate anti-secretory agents and other things that can be added to clear the PUD entirely. That is how you you manage it. But you first confirm, go after etiologies, choose the appropriate regimen. Please, are you okay?
Yes, please.
All right. So now, whenever you want to treat any condition, you set your goals of therapy. These goals of therapy are the ones you attack. And if you do it very well, you'll be successful. So for PUD, of course, the strategies will depend on the etiology, whether there is H. pylori or not, whether the patient is on NSAIDs or not, or whether all of these things are not there, but there is PUD. But in general, you have to consider. So the treatment depends on the etiology of the ulcer. Is it H. pylori induced? Is it NSAIDs induced? Is it stress induced? Is it whatever? You need to consider that. Then is it the first time or it is something that has been there and recurring? You need to also find out that. Are there complications? Bleeding, perforations, obstructions, and those things. Because all those things, if they are there, they will impact or affect the way you treat. But overall, be it whatever etiology or whatever, the overall goals include relieving the symptom of pain, because it comes with epigastric pain, very uncomfortable. And the target is to heal. You need to heal the ulcer. Prevent recurrence. We don't want to see that. And then development of any complications, we don't want to see. If they're already there, we manage. Of course, we don't want the patient to suffer from morbidities and mortalities. And overall, we want to improve the patient's quality of life. These are the general goals. But specifically, if it is detected that it is H. pylori induced, then in addition to the general goals, obviously we are going to consider adding, eliminating H. pylori to the goals of therapy. So you can see that the general goals, we did not consider elimination of H. pylori because this is for all possible etiologies. But when it is detected that it is H. pylori induced, then of course we need to eradicate the H. pylori in addition to the general goals. If you are able to do so, if you are able to successfully eradicate H. pylori, this is what you benefit. You are at the chance of reducing the risk of recurrence to less than 10% at 1 year. If you're able to reduce or clear H. pylori, you reduce recurrence rate to less than 10% at 1 year. That is how beneficial it is if you are able to eradicate successfully the presence of H. pylori. Now, let's look at non-pharmacologic strategies. As I said, there are certain issues that you don't need to stress yourself too much. It is just by way of counseling. So if you are always putting yourself in stressful conditions, or there is an underlying stressful issues, manage that stress. If it is critical illness, manage. A cardiac infarction, stroke, what have you, manage. If you manage, the stress will go down and then the ulcer will start healing. If you smoke cigarettes, please stop. Stop. As simple as ABCD. If you are on NSAIDs and it can be avoided, please stop, including aspirin. Stop. Any food or beverage that can exacerbate or contribute to the ulcer in any way, please stay away from them. And for complications, if it demands that they do emergency repair, exploratory laparotomy with repair, please, they have to do it. That's also a non-drug approach. So in case of bleedings, perforations, or obstructions, then there's general surgery guys who have to come in and perform exploratory laparotomy, resection and repair. They cut and join and repair. So they can also do that to help you. How about pharmacological interventions when you have H. pylori there? When you have H. pylori there. So first line recommended strategies is to use the so-called triple therapy. So the proton pump inhibitors base. Now, before I continue, as captain, I would urge you to please go and read on the anti-secretory agent. As for your antibiotics, I know that it is top-notch. If it's not top-notch, please go and read on your antibiotics, because we are going to use antibiotics here. Then the anti-secretory agent, too, please go and read on them. Basically, the H2 receptor antagonist and the PPIs. Please get some nice pharmacology or some nice literature, and then it's the same information. Nothing much has changed. So get any very good pharmacology or even any published data that contains pharmacology of PPIs and H2 receptor antagonists and read on them. Now, the triple therapy has it that you use a proton pump inhibitor base. So you use a proton pump and you add 2 antibiotics. The recommended antibiotics are 3 for the triple therapy regimen. It includes clarithromycin, metronidazole, and amoxicillin. You choose 2 from these 3 antibiotics. You add the PPI to it for the so-called triple therapy in your quest to eradicate H. pylori. And now the question is that, why are you combining all these, especially 2 antibiotics plus the PPI? To manage that. Normally, bacteria, they are mostly dividing. The vegetative stage when they are actively growing, compared to when they are in the dormant stage. When they are in the dormant stage and not dividing, they are more defensive than when the environment is conducive for them and they are actively dividing. So yes, we said that the acid environment is hostile to what? H. pylori, and therefore it is able to neutralize it. But if it gets any help, that will make its work a bit lesser. Of course, PPIs, when they come in, they minimize the acid as well. So this will make the environment more conducive for what? H. pylori. Then the H. pylori will be used to what? Proliferate. At that point, that is where H. pylori is most susceptible to the antibiotics. And therefore, combining the PPIs, that will make the environment less acidic, will promote proliferation of the H. pylori. At the same time, H. pylori is susceptible to the antibiotics. So the antibiotics, together with the PPIs, they work better when it comes to the eradication of H. pylori compared to using only the antibiotics to manage. And therefore, you get better response when you do the combination, the triple therapy, better results, better outcomes as compared to using them individually. That is why the triple therapy is very, very effective. So 1 PPI plus 2 antibiotics. Choose from clarithromycin, amoxicillin, and metronidazole. In case you do it not less than 7 days, but preferably 10 to 14 days, and you are not successful, you have to repeat. So you have done the first course, you go and check, and the test is still positive. You have to repeat, meaning that the antibiotics were not able to kill it. So in your second attempt, it's only sensible for you to change the antibiotics. Don't go in there, provided the person was able to comply with the medications. And therefore, there is nothing wrong with compliance. Yes, if that is, then you may repeat it. But if everything is on point, but it is truly that you were not able to kill it, then you have to change the antibiotics and come in. Or you switch to the alternative, the quadruple therapy that contains the PPI with bismuth subsalicylate, metronidazole, tetracycline. So 3 antibiotics or 3 anti-infective agents with a PPI. So a PPI with bismuth, metronidazole, and tetracycline can also be considered as the next line of action. But the first time, you can change the antibiotics to the ones that wasn't used, or you do the quadruple therapy. The quadruple therapy, however, is very difficult for patients to comply. Now, after everything, if you successfully eradicate, some patients may still show some few signs and symptoms. In those patients, they will have to continue with the anti-secretory agent for some time, normally about a month, 2 weeks to 1 month. So those individuals will have to be on maintenance anti-secretory therapy to the time that we are sure that the signs and symptoms regimen. So you have PPIs here, the antibiotics that we always choose to. So for example, the first regimen, they are using esomeprazole and they are choosing Amox with clindamycin. This is what they call the PAC 500, PAC substrate 500, PAC the substrate 500. Very, very effective, and simply because it is easily esomeprazole, BD, Amox, 1 gram BD, clindamycin, BD. So it's easy to comply, better than when you are taking metronidazole and you are going to do it TDS with Amox, TDS. Compliance rate to be better in this, and the antibiotics too are very strong. So these are all possible regimens that can be chosen as first line for H. pylori eradication, the so-called triple therapy. Yeah. So for NSAIDs induced, you will have to still test if H. pylori is there or not. If H. pylori is there, then you are going by the H. pylori regimen. If H. pylori is not there and it's only NSAIDs, stop taking the NSAIDs. You are not adding antibiotics. You do your usual anti-secretory agent, PPIs or A2 receptor antagonists. Now, if it happens that stopping the NSAID is not possible, then you may have to consider cytoprotection. What is cytoprotection? Still taking the NSAID, obviously, for the shortest possible time and at the lowest effective dose, plus a PPI. So you take a PPI or misoprostol in addition to the lowest effective dose of the NSAID for the shortest possible duration of therapy. I repeat, cytoprotection. It means that you can't stop your NSAID. That is possible. What do? Take the NSAID with the lowest effective dose, the shortest possible duration of therapy, with a combination of misoprostol or a PPI to protect the GI lining. This is what we call cytoprotection. Or you switch to selective COX-2 NSAID, notably celecoxib. Rofecoxib is no more on the market due to cardiovascular issues. It has been declassified. It has been withdrawn. So the only remaining example in Ghana, for example, is celecoxib. You can also switch to that selective COX-2 inhibitors, selective COX inhibitors. You can switch to them. This is what we mean by somebody doing cytoprotection. Back to the H. pylori induced. This is an alternative regimen to the first-line triple therapies. So if you are not...
Doc, please, can you repeat the cytoprotection part?
Yes, so cytoprotection, somebody is having NSAID-induced ulcer, but we just can't stop the patient from taking the NSAIDs. Let's say, I don't know, it could be any situation where it is still important for the patient to be on NSAID. In that situation, you have to use the lowest effective dose of the NSAID, and the duration should be the shortest duration of therapy possible. So the patient will be on this and you add GI protective agents like misoprostol. Misoprostol is a synthetic analog of prostaglandins, E2, or you add a PPI to the NSAIDs. So this is what we call cytoprotection. Another strategy is you switching from a non-selective COX inhibitor to a selective COX-2. Here in Ghana, celecoxib is what we have here. You can do that to minimize the effect of NSAIDs on the patient ulcer. Please, are you okay?
Yes, please.
All right. So back to the H. pylori.
Chef, I have a question.
Okay.
And please, is switching to a COX selective one also cytoprotective?
Of course, because your strategy is to minimize the harmful effects, be it using the anti-secretories or using the misoprostol. But normally we give A2 when we add either misoprostol or adding PPI. But switching to a less harmful agent is also cytoprotection. It's because of cytoprotection why you are switching. So they are all cytoprotective strategies. Are you okay?
Yes.
Making sure that you only attack the bad COX and leaving the good COX. That is cytoprotection. All right. Now, in case.
But, sir,
hello?
So, please, can you add the cytoprotection to celecoxib?
Oh, that's not necessary. Because it is the COX-2 that will give us the harmful effect on the GIT. So if you have selectively blocked the COX-2, then it's not necessary for you to add that one.
Is that because they are saying it's not 100%?
Yeah, but it's not necessary. It's not necessary.
Thank you.
It's not necessary for you to do that. Okay. All right. So if, let's say, you don't have the chance to do the triple therapy, it's not available, or you've lost confidence in triple therapy, we also have the sequential therapy as an alternative therapy to the triple therapy. So the triple therapy, yes, that is first line. But the sequential therapy is also an alternate first line regimen. So you can use the triple therapy, or currently you can also use the sequential therapy. Sequence. You start something to some point, then you continue with another thing from there. So the first in the sequence is a double therapy using a PPI at a standard dose, that is BD. If it's omeprazole 20 milligram BD, esomeprazole 20 milligram BD, plus high dose amoxicillin BD for 5 to 7 days. That is the first in the series. So double therapy, PPI standard dose with Amox 1 gram BD for 5 to 7 days. So that's the first thing. Then that will not be the end, since it is sequential. You continue with a triple therapy containing PPI standard dose, clarithromycin standard dose, and either tenidazole or metronidazole, not the usual TDS, but rather BD. In Ghana, we will still use the 400 BD because we don't have the oral 500 here. So you start with double therapy, Amox and PPI, both BD, Amox 1 gram for 5 to 7 days. Then you continue with 3 drugs, again a PPI, clarithromycin, plus tenidazole or metronidazole, or in BD. So PPI BD, clarithromycin 500 BD, metronidazole over here 400 BD, again for 5 to 7 days. This is what we term the sequential therapy. It is an alternate first-line therapy. An alternative if you don't like the triple therapy, the usual one, you do this. Please, are we okay? Are we okay?
Hello, Doc.
Yeah, hello.
Please, with the sequential therapy and then the table you presented earlier, I realized that the clarithromycin in combination with metronidazole, clarithromycin was 250 milligram.
Yeah, so it depends on which regimen you want to do. They are different. So, like when you are combining Claritro and Metro, you don't do the usual 400. You reduce it. So you need to look at the doses very well, not only the drugs, depending on the combination that you want to do. So always check. These are all from BNF. So you always check. When you are combining Claritro and metronidazole, how do you do it? If you are combining this and this, how do you do it? If you are just check, you just go and refer and then you do it. So Claritro with Metro, Claritro will be reduced to 250, then Flagyl will be 4. If you are combining Claritro with Amox, it will maintain 8,500, and then the Amox will be 1 gram. That is the pack 500. If you are combining Amox and Metro, everything changes to the TDS. Normally, that is how it is done. Hello? Hello?
Hello.
Yeah, so you can have Amox 500 TDS with metronidazole 400 TDS and a PPI like omeprazole 20 BD. It depends on which combination you decide to go with. Just make sure that you always refer. You can always check from the BNF and choose the appropriate doses depending on the choice. Please, are you okay? Likewise, if you are doing the sequential, you have to make sure that you get the doses right and the choices also right. Are you okay?
Yes, sir.
All right. Then we have a salvage therapy. So that one will come in case the patient fails on the initial regimen. That is either the alternate first line or the triple therapy. Then you do the salvage. So the salvage will include the bismuth-based quadruple therapy, the one that you do your metronidazole with bismuth, with tetra, and a PPI. Very difficult to comply, but you have failed first line. So what do? You don't have any choice. Or you do the levofloxacin-based triple therapy for 10 days. So this one, it means levofloxacin, the fluoroquinolone will be part. So you do your PPI, that one, it's comprised of PPI standard dose. That is if omeprazole 20 BD, esomeprazole 20 BD. Then the levofloxacin 500 daily. Over here in Ghana, that will be the most common because the tablet comes as 500 milligram per one. Then you add amoxicillin, standard dose. So this 3 is also, I think this one will be easier than doing the bismuth-based quadruple therapy. In case you fail the first line agent, you can do salvage therapy. So 2 recommended salvage therapies for those who have failed the first lines, either triple or the sequential. These are first line therapies. If they don't work, the salvage will come in. Then elsewhere, yes, so this is the quadruple therapy, the composition. And then we have third line. So the third line, if you failed salvage, you are going to third line. So third line, it means that first line has failed. Salvage, which is like second line, has also failed. What do you do? At that point, you might have used or you try your third action. So it means that H. pylori is stubborn and not susceptible at all. So your third fight, third world war, you have to do your sensitivity test or the susceptibility test before you throw in the antibiotics that will be active against it. So at this point, normally, you may consider unusual agents, even including rifabutin. It may be active and therefore be included at this time. So at this point, it is based on susceptibility testing that you choose the antibiotics that will be active against the H. pylori. So first line, triple therapy, and then the sequential, you won't test. It's not necessary for you to test. Salvage, no problem. Either the levofloxacin or the quadruple. But if you fail these two, then enough is enough. You have to go and check before. With that, you'll be guided to choose the appropriate antibiotics that will be effective. Again, you repeat your PPI in addition to the agent. And because the organism is stubborn, you are not going to choose less than 2 antibiotics during the third line therapy. You are still going to use at least 2 antibiotics that can kill the H. pylori from the susceptibility test that you do. It is our usual culture and sensitivity test that I'm talking about. That is the susceptibility test that you do. So third line therapy is guided by culture and sensitivity testing. You choose 2 antibiotics, you add your PPI. Please, are we okay? Are we okay? What is the time?
6:02 is time.
Oh, okay. So then let's quickly look at these other regimens. These are normally the regimens that
Doc,
are...
please, it's...
Hello?
Doc, please, I was saying it's 6:03.
Oh, okay. So then let's close. Next week, when we meet, we will start from here. We will look at this relatively newer regiment. The hybrid regimen, the load regimen, the levofloxacin, and those things. They are also available. Some clinicians have started prescribing them, so we will look at them. They are always available in reference. So fine, if you can put it there in your head, fine. If not, when the clinician needs your help, you can always refer and then give some of these unusual regimens to, as in our context. You can always do that. So next week, Sunday, we will start from here. Somebody was asking a question, no?
Yes, sir. I just wanted to ask if maybe you could quickly summarize the special therapy for me. Thank you.
Which one? The treatment?
Yes, the treatment.
Okay, so the treatment, as we said, you have to consider the etiologies, whether it's NSAID-induced, H. pylori-induced, or none of these are there, because it will help you. So the moment, for example, you realize that is an NSAID-induced, then of course you need to move the NSAID out if possible, and then you do your PPIs. If you can't stop the NSAID, then you maintain your PPI, you do your NSAIDs, but at the lowest effective dose, the shortest duration of therapy possible, plus doing cytoprotection, adding misoprostol or a PPI to it, or you switch to COX-2 selective inhibitor like celecoxib. Of course, you should also test for the presence of H. pylori, even if it is NSAID induced, because if it is there, then the whole game changes. If it is there, you consider all this and then you add your antibiotics. If it is truly H. pylori induced, then of course you are going to consider your antibiotics plus PPIs. Why? Because we have discussed that combining the two makes the treatment outcomes better than doing, say, only the antibiotics or only the PPIs for obvious reasons. In that case, we have first-line therapies, first-line recommended therapies. We have the triple therapy. The triple therapy is where you always choose from these 3 antibiotics, erythromycin, amox, and flagyl. You choose 2, then you add it to a certain PPI. I've been mentioning PPIs, of course. We said they are superior. I said you should go and read on PPIs and H2 receptor antagonists. You will find issues like superiority of PPIs over H2 receptor antagonists, and then the effectiveness of H2 receptor antagonists for nighttime symptoms over PPIs. You are going to find all this, and their general adverse drug reactions and what have you. then their mechanism of actions, how they are activated. Within the PPI class, the differences between them in terms of inhibition of enzymes of metabolism and what have you. Yes. So if you are doing H. pylori, you choose the triple therapies. There is an alternative first-line therapy called the sequential therapy. That is when you do the PPI with Amox for 5 to 7 days. Then you come and do the triple therapy, PPI with Clarithrol and metronidazole, tenidazole, over another 5 to 7 days. That's sequential. If first-line therapy fails, then you do the salvage. So the salvage could be the levofloxacin base or the quadruple therapy. If this one fails, then enough is enough. You do your third-line therapy based on susceptibility test. So you do your culture and sensitivity test, and whichever antibiotics that the H. pylori will be susceptible to, you choose at least 2, because you are dealing with a very stubborn agent, plus your anti-secretory agent, preferably a PPI. That is what you do. That's what you do. Then we got to this slide where we have other regimens, very, very uncommon, but some clinicians are using them, termed hybrid regimen, the load regimen, levofloxacin triple regimen, and then levofloxacin sequential. These are all there that can help when managing peptic ulcer disease caused by H. pylori. So next week we will start from here, and then we move to stress ulcers and what have you. Any queries? Any queries? So whenever we are done, I will send the slides to you. I'm sorry for that, but I want you, and I hope you are also writing certain information. But I may say something that may not be part of the slides. These slides are just some key points for the presentation. They may be scanty, but you need to be writing certain notes down so that you can use it. When you get the slides, you combine the two. All right. Class captain, any announcement or anything that you want to inform the group? Or does anybody has anything to say? Any questions?
All right. So number one would be that, Doc, please, can I be heard?
Yeah, sure.
Doc, please, can I be heard? All right.
Please
so
go
number
on.
one would be that for those who had issues with their Gmail, they are required to provide an alternative Gmail, but it should be in similitude with their names. That's number one. Number two would be that when there's an online lecture, you kindly want to encourage that don't be calling the class rep or even Fambobo. The reason is that once you do, it sometimes disrupts. I use Telecel and I have only one SIM. So once you call, it disrupts my connectivity with the lecture. So that is the second thing. The third is that the third would be that we should respond to messages with some immediacy. Yesterday, we were given a 30-minute lapse to respond to the Gmail. Sadly, we didn't have responses from the students. So please, when you are given an opportunity to make your inputs, please do well to work with the time given. And as Fambobo indicated, lecture notes will be sent almost always after the lecture, as well as on Monday we should have the Google Drive. So those are the announcement. Thank you.
All right, thank you very much. So finally, any issue or anything to what class captain has just said? If you have anything to say about the information from the class captain, please let us know. If not, then I'll thank you very much for your audience. Same time next week, we will meet. Don't worry, Prof. Takra will be in soon, and he will start with cardiovascular topics. Enjoy the rest of the day. Thank you very much. See you same time next week. No, we are going to meet even on Saturday. All right, all the best.